Hi friends, from today onward I am going to start a new topic that is fluid therapy. In this I will be discussing the various fluids, their compositions, their indications, their contraindications, and particularly in this video this is a basic physiology video. We will discuss about the physiology of the body fluids in in a human being, and to some extent some commonly used terms like moles, millimoles, osmolality, and their uses in day-to-day practice. First is the disclaimer. My Caring Docs YouTube channel does not provide medical advice, and information provided on this channel does not offer diagnosis or advice regarding the treatment. Information provided by this channel is for educational purpose only, and information provided is not to be used as an alternative to healthcare professionals' diagnosis or treatment of any person or animal. Please seek the help of a medical expert for diagnosis, prevention, and treatment of the medical illness. There is no endorsement for any brand or a company. If we see the basic physiology of the body fluids, we know that total body water content is about 60% of the lean body weight in a young adult male, and it is about 50% in adult female. Fat contains less water in an obese person, so the obese person will have proportionately less body water as compared to a lean person. In newborn infants, the proportion of the body water in relation to the weight is 80%, which declines with the age. The total body water is distributed in two compartments: extracellular fluid compartment and intracellular fluid compartment. Two-thirds of the body fluid, that is 40%, is intracellular fluid, and one third, that is 20%, is the extracellular fluid. This extracellular fluid is further subdivided into intravascular and interstitial space in a ratio of 1 is to 4. If we take the example of a 70 kg person, and if we consider 1 kg as 1 liter, then the total body fluid will be 60% of 70 kg, and that will be 42 liter. And this 42 liter is further subdivided into extracellular fluid and the intracellular fluid. As we know that extracellular fluid is one third, so it will come out to be 14 liter, and the intracellular fluid will be 28 liter. The extracellular fluid is further subdivided into interstitial fluid and plasma. As we know, interstitial fluid is 3/4 of the extracellular fluid. It will be 10.5 liter, and the plasma will have only 3.5 liter of the body fluid. Friends, fluid intake, whether it is oral or IV, and the urine output, both these intake and urine output are important parameters for the body fluid balance, and kidney plays an important role in this. To determine the daily requirement of the body fluid, we must know the insensible fluid input and output. Insensible fluid input is 300 ml of the water due to oxidation, and the insensible fluid loss, the fluid which is lost through lungs, skin, and the stool. These are all insensible fluid losses. And we know that about 500 ml fluid is lost through skin, 400 ml of the fluid is lost through the lungs during expiration, and about 100 ml is lost in the stool. So fluid loss minus fluid input is equal to 1000 minus 300 ml. This comes out to be 700 ml. The normal daily insensible fluid loss is 700 ml. So approximately 700 ml of fluid is lost by the body as an insensible fluid loss. But when patient does vigorous exercise or has a severe sweating, as in high fever, about 1 to 1.5 liter of the fluid may be lost, and about half to 3 liters of the fluid is lost when patient is exposed to burn, or has a or undergoes any surgery like laparotomy. So the patients who has so the higher physical exercises, abnormal sweating, fever, burns, surgeries, they will account for high amount of water loss, sorry. The basic information This basic information help us to calculate the daily fluid requirement in patients on IV fluids. In normal person, the daily fluid requirement is sum of the urine output and the insensible losses. In normal person, daily insensible loss is 700 ml, so the daily fluid requirement should be urine output plus 700 ml. After water distribution, let us discuss about the distribution of the electrolytes in the body. We know that in extracellular fluid, sodium is the major cation, and potassium and magnesium are the major cation in the intracellular fluid. And the major anion in extracellular fluid is chloride, and phosphate, sulfate, and proteins are the major anion in intracellular fluid. So, if we see the electrolyte concentration of the body fluids, sodium is the major cation in the extracellular fluid and it accounts for 142 milliequivalent approximately. And the major anion in the extracellular fluids are the chloride and bicarbonate, which account for 104 milliequivalent, and bicarbonates are 24 milliequivalent in extracellular fluid. And similarly, in intracellular fluid, potassium and magnesium are the major cations, and potassium is 150 milliequivalent per liter in intracellular fluid, and the magnesium is 40 milliequivalent per liter in the intracellular fluid. Phosphates, sulfates, and proteins, they are major anion in the intracellular fluid. Let us discuss about basic terminologies. Anion is the ion which has a negative electric charge, like chloride, bicarbonate. Cations have a positive electric charge, like sodium, potassium, magnesium, calcium, aluminium. Just remember, anion has a N, so it is a negative charge. There are different ways by which solute concentration can be measured. It can be measured as a milligram per deciliter, milliequivalent per liter, millimoles per liter, or milliosmol per kg. Moles and millimoles, let us discuss what are they. Basically, mole is a specific quantity. One mole of any non-dissociable substance contain the same number of particles, approximately 6.023 into 10 raised to power 23. So 1 millimole of sodium contains the same number of atom as 1 millimole of chloride, even though their atomic weight differs. That is, 1 millimole contains 23 milligram of sodium, and it is against the 35.5 milligram of chloride. 23 is basically the atomic number of atomic weight of the sodium, and 35.5 is the atomic weight of the chloride. It is just as if 1 dozen of mango and 1 dozen of banana are compared, then their numbers are same but weights are different. So mole of any substance is defined as a atomic or the molecular weight of that substance in gram. Similarly, 1 millimole will be equal to 1000 of the mole or molecular weight. This picture shows atomic and the molecular weight of important solutes in the body. Like calcium has a molecular atomic weight of 40, chloride ion has a 35.5, hydrogen has 1, oxygen has 16, potassium has 39, sodium ion has 23. So the atomic weight of sodium is 23, that is 23 milligram is 1 millimole, and 23 milligram of sodium in 1 liter of water presents as a sodium concentration which is 1 millimole per liter. Coming to the equivalent and milliequivalent, equivalent is basically a relative term. It refers to the mole of ionic charges. An equivalent is the atomic weight in grams multiplied by valency. For ions which carry a single charges, the moles will be equal to equivalent if the ions have a single charge, whether it is a plus or minus, like sodium, potassium, chloride, and hydrogen. They They can be written as millimoles per liter or milliequivalent per liter because their valency are the sorry their charges is only one. So if we multiply it with the moles with the valency, we will get it as equal to equivalents. But if the ion carries charges greater than 1, then the mole will not be equal to equivalent. Here, just remember the formula as equivalent is equal to moles into valency. For example, a mole of calcium is equals to 2 equivalents because calcium has a valency of plus 2. So we can remember from this picture that sodium has a one positive charge, so it can be written as a milliequivalent per liter and millimole per liter. Both are same. Same is the case with potassium, but calcium has a plus 2 charge. So if it is written as a 1.25 millimole per liter, then the if we have to write equivalent, then 1.25 into we have to multiply it with its valency, that is plus 2, and we will get 2.50. Same is the case with magnesium. Same, since chloride and bicarbonate they have only single charge, their mole and equivalents are same. The values of calcium and magnesium, they include only the ionized form of these ions. Molecules must be quantified in moles. Moles of, for example, these in these values, milliequivalent and millimoles are used for the ions which carry positive or the negative charges. But there are some solutes like glucose, urea, creatinine, proteins. We usually express them as a milligram per deciliter, and we don't write as them as a millimole per liter. Just remember the formula: millimole per liter is equal to milligram per deciliter into 10 divided by its atomic weight. So only the ions which have a charge, that is plus or minus, they are expressed as a moles or equivalents. Just remember few formulas to convert from milligrams per deciliter to milliequivalent per liter. The formula is milliequivalent per liter is equal to milligram per deciliter into 10 into valency divided by the molecular weight. Let us take the example. If 1 gram of sodium chloride is added to 1 liter of water, then what will be the concentration of sodium chloride in milliequivalent per liter? 1 gram of sodium chloride in 1 liter is equal to 1000 milligram per liter, and that will be 100 milligram per deciliter. Valency of the sodium chloride is 1. Molecular weight is 58.5 because sodium has a molecular weight of 23, chloride has a molecular weight of 35.5, and if we combine both, we get molecular weight of sodium chloride as 58.5. If we apply this in formula, then we get as 17.1. So the 1 gram of sodium chloride per liter will be equal to 17.1 milliequivalent per liter. So 1 gram of sodium chloride will contain 17.1 milliequivalent of sodium, 17.1 milliequivalent of chloride, or sodium concentration of a sodium chloride will be 17.1 milliequivalent per gram. To convert milliequivalent to milligram per deciliter, the following formula can be used, as milligram per deciliter is equal to milliequivalent per liter into molecular weight divided by 10 into valency. For example, if 1 liter of sodium chloride solution contains 154 milliequivalent of sodium chloride, how much milligram per deciliter is the amount of sodium chloride? Sodium chloride milliequivalent per liter is equal to 154. Molecular weight is 58.5, valency is 1. just apply this in formula. So we will get sodium 154 milliequivalent per liter of sodium chloride will be 9009 milligram per liter, or we can say 900.9 milligram, sorry, 900.9 milligram per deciliter. So 1 milli equivalent per liter is equal to 58.5 milligram per liter, or 1 milli equivalent contains 58.5 milligram of the salt. If we look at these values derived at the end of both these equations, the sodium concentration is 17.1 milli equivalent per gram of sodium chloride, and 1 milli equivalent contains 58.5 milligram of sodium. It looks little bit tough. Just remember, when you will practice it, it will be easy for you to remember. Otherwise you can just remember this conversion formula. Here the salt, like sodium chloride, if we express as a milliequivalent per gram of salt, it is 17, and milligram of salt per milliequivalent it is 58. For potassium chloride, the milliequivalent cation or anion per gram of the salt is 13, and milligram of the salt per milliequivalent is 75. Similarly, for bicarbonate it is 12 and 84. For calcium gluconate it is 4 and 224. For calcium chloride it is 14 and 73. For magnesium sulfate it is 8 and 123. Let us take few examples of the conversion. If we have to find out potassium concentration in milliequivalent in 10 ampules of 15% potassium chloride, then the 10 ml of 15% potassium chloride is equal to 1.5 gram of potassium chloride per ampule. As we know that 1 gram of potassium chloride contains 13 milli equivalent of potassium. Just see the previous table, potassium chloride has 13 milli equivalent. So 1.5 gram of potassium chloride will be 1.5 into 13, we will get 19.5 milli equivalent of potassium. So the 10 ml ampule of 15% potassium chloride will contain 19.5 milli equivalent of the potassium. Let us take another example. If we have to find out sodium concentration in milliequivalent in 25 ml ampule of 7.5% sodium bicarbonate, then 25 ml of 7.5% sodium bicarbonate is equal to 1.86 gram of the sodium bicarbonate per ampule. 1 gram of sodium bicarbonate contains 12 milliequivalent of the sodium. Let us see in the previous table, sodium bicarbonate has 12 milliequivalent. So we apply this in here. So we get 1.86 gram of sodium bicarbonate is equal to 1.86 into 12, we get 22.3 milliequivalent of sodium. So 25 ml of ampule of 7.5% sodium bicarbonate will contain 22.3 milliequivalent of the sodium. Coming to the osmotic pressure and the osmolality. Osmotic pressure determines the distribution of the water among the different fluid compartments, particularly between the extracellular fluid and the intracellular fluid. The osmotic pressure generated by a solution is proportional to the number of particles per unit volume of the solvent, not to the type, valency or weight of the particle. So osmotic pressure depends on the number of particles per unit volume of the solvent. To generate osmotic pressure, solute must be unable to cross the cell membrane. Osmol, it is a unit of measurement of osmotic pressure. 1 osmol is defined as 1 gram molecular weight, that is 1 mole, of any non-dissociable substance such as glucose, and it contains 6.023 into 10 raised to power 23 particle. Milliosmol will be 1,000th of that osmol. So for relatively diluted fluid, body fluids, the osmotic pressure is measured in milliosmol per kg of the water. An osmol of a substance such as glucose, which does not dissociate into ions, is same as mole. However, A mole of salt such as sodium chloride, which dissociate almost completely into sodium and chloride, equals to 2 osmoles. Coming to the osmolality and the osmolarity. Osmolarity and osmolality, these values they reflect the relationship between the solute and the solvent. Osmolality of a solution is determined by amount of the solute dissolved in a solvent, for example water, which is measured in weight in kgs. If solute is dissolved in 1 kg of water, that is solvent, the concentration of the solute is called osmolality, and it is expressed as a milliosmol per kg of the water solvent. When osmolality is high, solution is more concentrated, and vice versa. That is, when osmolality is low, the solution is diluted. Coming to the osmolarity of a solution is determined by amount of the solute dissolved in a solvent measured in volume, that is liter. Osmolality is solution amount of solute dissolved in solvent when it is measured in kgs, and osmolarity is when the solute is dissolved in solvent which is measured in volume. If a solute is dissolved in 1 liter of water, the concentration of the solution is called osmolarity and is expressed as milliosmol per liter. So osmolarity is expressed as a milliosmol per liter, and osmolarity is expressed as milliosmol per kg. Just remember, solvent is measured when solvent is measured in liter, it is osmolarity. When solvent is measured in kilogram, it is osmolality. As the temperature can affect the volume of the solvent as well as volume of the solute in the solution, so it can affect the values of osmolarity of that solution. So osmolarity, which is determined by weight of the solvent, is more accurate than the osmolarity. However, the difference between these two values is negligible, and osmolarity is easier to measure, so is to be used more commonly. Osmolarity of any solution is measured by the measurements of its freezing point. Plasma osmolality is determined largely by the sodium salts, and to a lesser extent it has a contribution of other ions, glucose and the urea. Normal plasma osmolality is 285 and the range is 275 to 295 milliosmol per kg. Plasma osmolality formula is 2 into sodium plus glucose in milligram per deciliter divided by 18 and plus blood urea nitrogen in milligram per deciliter divided by 28. Effective osmolality. The effective plasma osmolality is determined by those solutes in the plasma which do not freely permeate the cell wall and act to hold water within the extracellular fluid. So the lipid soluble solute such as urea, which can cross the cell membrane, does not contribute to the osmotic pressure gradient between the extracellular fluid and the intracellular fluid. So urea, although contributes to the determination of the plasma osmolality, it does not contribute to the effective osmolality. Therefore, there is a difference between the total osmolality and effective osmolality. Formula for effective osmolality is 2 into sodium plus glucose divided by 18. Under normal circumstances, the glucose accounts for only 5 milliosmol per kg in effective osmolality. So, normal plasma sodium concentration is the main determinant and reflector of the plasma osmolality. Whenever we have to initiate the fluid therapy, for proper fluid therapy, we should always know the etiology of the fluid deficit, types of the electrolyte imbalance present, associated illness like diabetes, hypertension, ischemic heart disease, or renal or hepatic disorders. We have to see the clinical status of the patients with regards to its hydration, vitals data, urine output, etc. For rational use of IV fluid, we should always have few questions in our mind: when to give IV fluid, when to avoid, which fluid is to be given and why, how much fluid should be given and how to calculate it, rate at which IV fluid is to be given, how to calculate the drop rate, of the IV fluid, what are the contraindications of different fluids and why, how to correct the electrolyte imbalances, and when and how to use specific fluids. So the basic principles of the fluid therapy. As a principle, the oral route is always preferred over the IV fluid, but IV fluid therapy it has a great importance in various clinical conditions. It has advantages like it is accurate, controlled, and predictable way of administration. Immediate response is achieved due to direct infusion in the intravascular compartment. Prompt correction of the serial fluid and electrolyte disturbances can be done. The various indications for starting the IV fluid therapy is condition when oral intake is not possible. For example, patient who is in coma or undergoing anesthesia or any surgery, patient who has severe vomiting or diarrhea, moderate to severe dehydration and shock when urgent and rapid fluid replacement is needed, patients with hypoglycemia. IV fluid therapy acts as a vehicle for various IV medications like antibiotics, chemotherapeutic agents, insulin, vasopressor agents, total parenteral nutrition, treatment of the critical problems like shock, anaphylaxis, severe asthma, cardiac arrest, forced diuresis in drug overuse, poisoning, urinary stones. Disadvantages of IV fluid therapy, it is little bit more expensive, needs strict aseptic precautions. It is possible only in hospitalized patient under skilled supervision. Improper selection of the type of the fluid can lead to serious complications. Improper volume and rate of infusion can be life threatening. Improper techniques of administration can lead to complications. IV fluid should not be used or should be avoided if patient is able to take oral fluid. We should avoid IV fluid, excess of IV fluid in patient with congestive heart failure or volume overload states. The complications of the IV fluids, as we know, at the local site, patient may develop hematoma, infiltration, and infusion phlebitis. Systemic complications are volume overload with rapid or large volume infusion, especially in patients with cardiac problem. Patient may have rigors, air embolism, and septicemia. Other complications like fluid at times may contain fungus, fluid may get contaminated, mixing of incompatible drugs, improper technique of infusion, IV set or IV catheter related problem, human error are the related problems. This picture shows the composition of the common IV fluids. For example, 5% dextrose, thus it has 50 gram of sodium in 1 liter, and there is no sodium, sorry, it has 50 gram of glucose in 1 liter. It has no sodium, potassium chloride, and any other solute. 0.9% saline has 154 of sodium, and chloride is also 154. It has a osmolality of 278. Similarly, dextrose 5% and 0.5 0.45% saline, that is DNS. It has a dextrose of 50 gram. It has a sodium of 77, chloride 77, and osmolality is 308. Dextrose saline contain, that was half dextrosaline. Now dextrosaline has 50 gram of glucose, 154 milliequivalent of sodium and chloride, and its osmolality is 432. Similarly, ringer lactate has a sodium of 130, chloride of 109, lactate 28, calcium 3, and the osmolality is 586. So you can remember the various values by going through this table. Just remember a few characteristics of some IV fluids. The ringer lactate, it is most physiological fluid because its constitution is similar to the extracellular fluid. That is, it has a sodium of 130, potassium 4, chloride 109, lactate are 28, and calcium is 3 milliequivalent per liter. The daily requirement of the sodium is about 100 milliequivalent in a normal human being, and this is 5.9 gram salt. So 1 gram of sodium chloride contains 17.1 milliequivalent of sodium. 1 liter of the isotonic saline contains 154 milliequivalent of sodium, or 9 grams of sodium chloride. So 650 ml of IV isotonic saline is enough to provide normal requirement of the sodium, provided there is no abnormal losses. Among the various IV fluids, the isotonic saline and DNS, they have maximum sodium, and isotonic saline and DNS isolate G have maximum chloride also. The sodium concentration in various IV fluids are: in NS and DNS it is 154, in isolate E it is 140, in ringer lactate it is 130, in isolate G it is 63, in 3% sodium chloride it is 513. Potassium concentration of the various fluid is shown as in ringer lactate it is 4, and in isolate M it is 35. So isolate M has a maximum of potassium, that is 35 milliequivalent per liter, while ringer lactate has just 4 milliequivalent per liter of the potassium. The IV fluid which can directly correct the acidosis are isolate E, isolate P, isolate M, and ringer lactate, because they contain acetate which gets converted into bicarbonate in the liver, and thereby that corrects the acidosis. A ringer lactate has 20 milliequivalent per liter of lactate. This lactate also gets converted into bicarbonate in liver, and thereby correct the acidosis. The fluids which can correct metabolic alkalosis are isolate G. It is the only IV fluid which directly corrects the metabolic alkalosis, because it contains ammonium chloride, that is 70 milliequivalent per liter. It gets converted into hydrogen and urea, and this hydrogen corrects the alkalosis. The fluids which should be avoided in renal failure. Fluids which are avoided in patients with renal failure are isolate M, isolate P, isolate G, isolate E, and ringer lactate. Because of the fear of developing hyperkalemia, IV fluids with high potassium like isolate M, isolate P, isolate G are used cautiously. The ammonium chloride in the isolate G gets converted into hydrogen ion and urea, therefore, it may aggravate uremic acidosis. And in severe uremic acidosis, conversion from the lactate to bicarbonate by liver may be impaired. So, lactate in ringer lactate may aggravate the metabolic acidosis. There are some fluids which should be avoided in liver failure also, like ringer lactate and isolate G. These are avoided in patients with liver failure. Lactate and ringer lactate gets converted into bicarbonate by the liver. In liver diseases, the lactate metabolism is impaired and it may lead to lactic acidosis, so ringer lactate is avoided. Ammonium chloride in isolate G gets converted into hydrogen ion and urea in the liver, and in liver disease this process is impaired, so isolate G leads to accumulation of the ammonium chloride, and the collection of ammonia may precipitate the hepatic coma or precoma. So isolate G is also avoided in severe liver diseases. The fluid which don't contain glucose are isotonic saline and ringer lactate. Therefore, they are preferred in the diabetic patient, and the fluid which do not contain sodium and chloride are dextrose containing solution like 45%, 10%, 20% are dextrose. They don't contain sodium and chloride, and isolate M and isolate P have low sodium and chloride. The fluids which does not contain potassium, they are isotonic saline, DNS, 5%, 10%, 20% dextrose. They do not contain potassium, so no fear of hyperkalemia in presence of renal failure. Fluids which do not treat metabolic acidosis and alkalosis directly, a dextrose solution, isotonic solution, DNS, they do not treat metabolic acidosis and alkalosis directly, because they do not contain acetate, lactate, or bicarbonate which correct the acidosis, or chloride, ammonium chloride which corrects the metabolic alkalosis. Coming to the classification of the various IV fluids, IV fluids can be classified as a maintenance fluid, replacement fluid, and special fluids. Maintenance fluids are usually given when there is fluid loss from the lungs, skin, urine, and the feces, and these losses are poor in salt. So this maintenance fluid should be hypotonic to plasma sodium. Routinely used maintenance fluid are 5% dextrose with half normal saline, and the replacement fluids, they are usually given to correct the body fluid deficit caused by the losses such as gastric drainage, vomiting, diarrhea, fistular drains, intestinal edema, oozing from the trauma, infections, burns. And the commonly used replacement fluids are isotonic saline, DNS, RL, isolated isolite M, P, and G. And there are some special fluids which are used in special indications such as hypoglycemia, hypokalemia, and metabolic acidosis. Commonly used special fluids are 25% dextrose, injection sodium bicarbonate, and injection potassium chloride. This was all about the basic physiology of some IV fluids. In the coming videos, I will be discussing about various IV fluids one by one, like 5% dextrose, inverted sugar solution, isotonic saline, 5% dextrose line, RL, and various isolate preparation like G, P, M, and E. Uh, Abraham Flexner has said that medical education is not completed at the medical school only. In the school, it only begins. The practice of medicine is the practice of lifelong learning. With this quote, I thank you all. Hope you like this video. Thank you very much.